Good morning and
Good evening. 2020 NCKU International Virtual Forum on COVID-19. Session 3, Global Research Partnerships, Scientific Innovations to Conquer COVID-19. Session Chair, Professor Weizhe Zhang, Associate Vice President of National Cheng Kung University. Professor Zhang.
good morning and good evening. It's my honor to host this session. In this session, we are going to discuss about global partnering. In particular, we are going to focus on scientific innovation. Slide, please. And in this section, we are going to have 4 events. The first event, we are going to discuss about the technology innovation. And the second part, we are going to have a panel discussion. And the third part, we are going to have special talks about, of course, international collaboration. And finally, the executive director is going to talk about the whole event. So first of all, we would like to have the first talk, please.
Yes, we're going to start the panel of invited speakers. Current interests include rapid diagnostic kits, testing and vaccination, smart medical treatments, information sharing, and others. Speaker, Professor Chong An, Microsystems and Biomass Laboratory, University of Cincinnati, the United States. Professor Chong An, you may start, please.
Hi, good morning, everybody. Can you see my screen?
Yes.
Okay, thank you. Thank you so much, Dr. Chang, for inviting us. I would say good morning in the United States, maybe absolutely good evening in there. The talk of my title today is to talk about the smartphone-based immunodiagnostics point-of-care testing platform for serological test of the COVID-19. Actually, I'm not talking about what is the really meaning of the serological test of the COVID. It's not my expertise, but how really immunologist and then a biologist can provide some specific antibody antigen or S protein, N protein antibody antigen pair, how I can quickly diagnostic more conveniently we can bring to the diagnostic to the near to the patient. Okay, my name is Chong An from University of Cincinnati. I don't want to repeat this one, but how to test the pandemic like COVID-19. Of course, we know the first we needed to molecular diagnostic, some RNA or DNA-based one. How rapidly diagnostic of the infection? We know everybody so far we're gonna doing well, but many problems. It's just it's a country without having appropriate molecular diagnostic at the beginning of this infection. But after molecular diagnostic, immediately serological test, another word by immunological diagnostic will be followed by the further validation of immunity of the COVID-19 and specifically asymptomatic patient diagnostic, right? How someone already infected but they didn't show about any symptom. That is the major threat of to fully control of this COVID-19. So I don't need to explain too much on that, but immunodiagnostic based on infection of the virus in here, and then body immune system can producing IgM and IgG responding to the classify proteins, especially this COVID-19 spike virus can produce S protein and N protein. As long as S protein, N protein in the body, and then our immune system responds to that, especially IgM and IgG can produce, right? After having IgM antibodies, how we can diagnostic based on so many ways, lateral flow assay, and then some quantitative, and then a qualitative assay, and then how we can laboratory more smartly can diagnostic of this one of the major concern in this time. So specifically, I'm gonna say everybody say how everybody can testing entire the population, some nations, some community, not only 1,000, 2,000, several hundred, several 10,000 million of the people. So we needed to rapid molecular diagnostic as well as immunodiagnostic platform. But I'm going to emphasize in here some individual levels, any possible individual levels, right? So everybody can test it by themselves or near to some patient. We're going to do more easily to diagnose it. But one approach to individual level of the diagnostic, we know already 3 billion people in the world have a smartphone. So my question in here, smartphone can be used as a personal analyzer or point of care testing for diagnostic of COVID-19 at individual level. That is my question, and then my major topics I'm gonna talk about in this presentation. So many groups tried to develop a smartphone-based, some point of care analyzer. As you see, some trend now. 2019, 2.7 million has smartphone. Now maybe this year we're gonna 2.8 or 3 million. 3 billion people have smartphone. So almost, how much is it? 30 or 40% of the population in the world has smartphone. So many research groups try to make how we a personal analyzer coupled to the smartphone, and then based electrochemical detection, optical detection, so many approach already has been done. But my groups generally we working on how we are making some more convenient, conventional immunodiagnostic coupled to the smartphone easily and then friendly, right? So our approach is smartphone in there, but we are using left side. I'm gonna talk this on later on, okay? Left side, we're gonna try to electrochemical chemiluminescence detection based one. So we use a dry assay, sequentially dry, and then microchannel capillary flow assay based one. We don't need to any external power, and then immunoassay, and then really bioassay can do it throughout the entire microfluidic chips, right? That is more easier because usually smartphone consumption of the power, so we don't need to spend too much power from the smartphone. And also some small portable decks, right? We're gonna do assembly of this analyzer to the smartphone more easily. And we can perform using these lab chips, right? And then as you see in here, very well known sandwich assay, and then competitive assay based on dry assay approach. Of course, this is the one example of the malaria diagnostic PF-HLP P2 capture antibody, and then antigen-based one approach. But this is the exactly similar approach we can apply to the COVID antibody antigen pair approach for that. So here's the concept in here, right? We're gonna do some magnifier. Left side, we have a smartphone in here. And then we have some analyzer, optical scanner decks is still carryable. And then bottom side of this one, our smart micro channel capillary flow assay without power consumption automatically can do all the assay within just 10 minutes, such kind of the timeline. And then eventually we're going to assemble this one, and then this smartphone using in as analyzer as well as display all the result. Of course, we're going to later on put AI or machine learning. We're going to all wireless networking and the communication will be possible based on the smartphone. So in here, my question, antibody test may hold close to COVID-19 exposure immunity. Yes, but it's a very complicated, right? The primary goal of the antibody test in here, at the beginning of the diagnostic of the COVID-19, maybe not, we're going to do first molecular diagnostic, but later, this can indicate those who have the illness at some point but never received the official confirmation of the infection, okay? And also some asymptomatic, so symptom-free infection. We are unable to have a clear out of this one. We continuously concern about infection in the future. And so based on this one, usually the unknown is how much immune response SARS-CoV-2, the virus caused COVID-19 tells us. Everybody now rushing to understand for this one. The early studies suggest the production of IgM, IgG for S, this is a spike protein, S and N protein produced COVID-19. Typically occurs 7 to 11 days later, but how we can understanding of this one, we can understanding immunity and then how we can compensation. So based on this one, this is the chip explanation. We're gonna do one chips, right? Sample put in your left side, and then detection antibody dry assay, and then also chemiluminescence assay, dry assay. They have a sequence for that. This chip is make a smarter sequence, and then finally test chamber, and then positive control, negative control. We can get eventually capillary pump. We can do all the assay based on chemiluminescence based one. Okay? So this is the chip design. Actually, we made some plastic chips, injection molded based one. So we can the mass producible of this one. Also, all dry assay. We're gonna semi-manufacturable approach for that. And this is the magnify of the especially the sequence at the connection point of that pass 1, pass 2 is detection antibody come first, okay, and then later on chemiluminescence reconstitute assay coming in here, right? So we can make automatic sequence. This is a major design of the chips. And then in the optical scanner decks, right, we can make a photo multiplier chips, okay, photodiode 3 of them, and then circuit designing to control of this one, communication between optical scanner and the smartphone, and then we can make a deck this one. Eventually, we show this one 3 component can assembly, okay, and then chip put on here, or later on, we are now sliding in over the chips for the right. So each of the tests we can 5 to 6% of the battery. Of course, now battery is going up or easier. So eventually we can do a test by this one, right? So this is a result of this one. We tried to smartphone result, smartphone based one. So we are top one. We leading smartphone based, right? Bottom one is a conventional leader. So both of them show the good trend of this one. We're gonna do this result can show the clue. Immunoassay based on smartphone and conventional are very similar. And then we are finally, right, totally sandwich immunoassay of the malaria, and we move into COVID, right? And then top black one assay result, the liquid substrate, but the red one, total dry assay of the reconstitute of the chips by using our smartphone. 2 of them, very good trend, and then LOD reasonably good, right? So after this one, we are display using this analyzer system. What is this one finally, right? App design. And then, so based on this, I can say we're gonna do serological test that can be possible by using smartphone assay. So my final answer, yes, a smartphone can be used as a personal analyzer for diagnostic of the COVID-19 at individual level. So of course we should do more works about this one, but hopefully soon to be everybody can using smartphone as some antibody antigen test for that. Thank you. This is actually my PhD student, Dr. Steve Todi, who was work on all of this.
Thank you very much. Thank you very much, Professor An.
Thank you.
Speaker, Associate Professor Nan Yao Li, Division of Infection, Department of Internal Medicine, NCKU Hospital. Professor Li.
Good night, everyone. Today we will talk about the care patient with a smart quarantine program in our hospital, National Cheng-Kung University. I'm now a director, Center of Infectious Control. Next time. Okay. Being a community of global community, we face many episodes of infectious disease every year. This time showed coronavirus as infectious disease pathogen, three major attacks about COVID-19. When 18 years ago, I'm a young physician. First time pandemic attack across coronavirus involved 17 countries. Total days with about 700 to up to the day. The COVID-19 to today is around about more than 16,000 people died across the disease. Okay, I think due to 18 years ago, SARS, a bad experience in Taiwan, total 11 healthcare deaths due to nosocomial infection. So the COVID-19 is also a nightmare for us. Next slide, please. The first case in Taiwan in January 21, the COVID-19 arrived. Although emergency exists, can play how impact in our community, also in hospital. We don't know, but respond to the crisis, we may be well prepared and well response. Next. I'll start stretch for crisis management. So we maybe identify the risk, cause disease, and planning where to minimize the risk. Otherwise, we setting a good planning to control the patient and stretch the patient. Otherwise, we may be a good crisis management to go into control the disease when the disease coming to our hospital. Next. So, when the first case report, our superintendent, Professor Semeng Lu, is creating a center of crisis response center and enroll many experts to treatment response and respond all everything related to COVID-19. Next. Okay. We also real-time collect the data. It can anytime to release the epidemiology about the disease. Also, patient care in our hospital. Also, we have enough equipment for patient care. So we can well prepare for, again, the COVID-19. Next. This overview of our hospital. According to 18 years ago, SARS attack, also we have the experience, so we may be out of the hospital. So we create a place, to set in a Q station and combine with combine the emergency department as a medical emergency block to provide emergency service when there is outbreak. This also to avoid or reduce NAS-CoMI infection in the major building, particularly inpatient building or outpatient clinical. Next. However, how to identify the risk of the patient? So we use the definition of Taiwan CDC definition. However, it's not a good idea due to the definition every change every day, even every hour. So two little steps. One is history about travel, occupation, and contact and trust. So we to identify where the risk factor is a risk patient for COVID-19. Otherwise, for medical service, for patients with illness such as pneumonia, we maybe arrange a future Medicare. So we maybe take a chest ray to confirm the disease severity. So if patient is a critical, maybe transfer to intensive care unit with isolating room. If mild disease also in general ward, but the two-class patient may be enrolled in airborne isolation room. However, the capacity over our loading, third, we may transfer to other hospital, but this may be through the public health agency. If the patient is stable, maybe also return home for self-care. If and disease developer, maybe return to medical care. Next. This early stage when the disease around Taiwan, so we use 10th stage. However, in the this is not suitable environment for walking. In Taiwan, it's very, very heat. So, particular the care patient or health worker under sweat. So many stress we finding next. So we change some program to improve the condition, to reduce the patient or care stress. Next. So we three steps to improving. One, we improve the hardware. We use a modular holder. The second, we introduction smart clinical assistant for patient feel the history by herself and induce the chest X-ray for diagnosis assistant. Next. So first of all, we working the hardware. So we shoot according the environment monitor and the adequate gas change to change the house temperature, humidity in the house. Also give a photodynamic agent as a new discontent can still clear the environment. Next. So we use a 3 program, keep the electromedical record and AI imaging interpretation, and finally combine the two criteria to make a clinical decision. This system maybe reduce the patient or health worker panic and stress in the element, also shorten timing and reduce cross-reaction. From before the system introduced, every patient may be waiting 2 hours. After induce the system, we may be need 30 minutes for care. Next. So we show the media. Is okay. Okay. Patient can feel by himself the history taking when he arrived at the Q station. Okay, we will next slide. Okay, next slide. Next time. Oh, next. Also, otherwise, from I guess the chest X-ray may be fighting for a senior doctor, but for young doctor maybe miss the reading. So we introduction the AI system. Next. So can hint lesion. So you have another color in the show, purple. So you can find in the lesion. Next. So we feel the smart system. So we improve the quantum efficiency. Next. So we demonstrate a video to respond to COVID-19 due to the past 3 months. This video, okay, return. The video can show. Return to the next. Previous slide. Okay. Video. Okay. Can I show? Okay. Due to time limit of thank you for or listen to the presentation. Thanks.
Thank you very much, Dr. Lee. Speaker, Professor Hans-Uwe Simon, Dean of the Faculty of Medicine and Director of Institute of Pharmacology, University of Bern, Switzerland. Professor Simon, you may start, please. Professor Simon? Yes, yeah, we are ready. We are ready.
You can hear me?
Yes.
Okay, wonderful. Dear colleagues, thank you very much for your kind invitation. I'm very happy being able to participate within this COVID-19 network and very much appreciate the efforts of our host. We have a long-standing collaboration with the National Cheng Kung University, and we exchange also students. So I'm very happy to serve you here also in the Congress to give you some ideas. What are we doing in terms of research activities of our university, the University of Bern? So I'm particularly would like to give you some information about COVID-19 testing and vaccination research in our university. May I have the next slide, please? The next slide, please. Yes, so we start with the testing. There are basically two different types of tests. So the first test would be that we detect the virus. This is done by a PCR analysis. And the second test is if we want to detect the virus-mediated immunity. So what did the virus do with our immune system? And here we detect the specific antibodies which are induced by the immune system. The next slide, please. Yes. So we are still talking about the virus detection test with the PCR analysis, and there are guidelines in Switzerland. When are you supposed to use this test? And the criteria for the virus detection test is that the patient should have symptoms, or it is a patient with an increased risk. For example, patients which are more than 65 years old, having high blood pressure, diabetes, heart vessel diseases, chronic respiratory diseases, immunosuppression, or cancer. Next slide, please. With this criteria, we follow also the advice of Thomas Bayes. Thomas Bayes lived about 300 years ago, and he thought about what is a good test. And he said a test should be used if it is likely that the patient suffers from the expected disease. So we are doing no testing in symptom-free patients. The next slide, please. So why do we follow this strategy? These are results from our university hospital just 10 days ago. At that time, we performed 4,716 tests. From those, we had 297 positive tests. So this is a rate of just 6%. So why we have such a low rate of positive tests? Next slide, please. May we have false negative data? Next, please. This seems to be indeed the case. So this is a publication which was published just last month talking about the sensitivity of the COVID-19 detection test by PCR analysis. And you see particularly if we take probes from the upper respiratory tract, the sensitivity of the test is very low. So we have many false negative tests. Next slide, please. So we are now talking about the second sort of a test where we try to detect virus-induced antibodies. Next, please. As Professor Ahn already mentioned, it takes some time until an antibody is produced. While the virus detection, we can already detect already within the first week after infection. It takes at least 2 weeks in order to be able to detect virus-specific antibodies. And we are doing that, next slide, please, with commercially available tests. Next slide, I show you some representative examples. Next slide, please. So these are 3 different patients. So the first one here is a 61 years old patient. Next slide. The next slide. Yes, and this patient was positive by PCR and he had also symptoms. and you see the patient developed IgG antibodies. Can you go back, please? No, you go back, please. Please go back. One more back. One more back. Yes, here. You have here the positive results. So this positive, we have a nice correlation between the PCR test and the ELISA. Now the next patient is PCR positive, but you see there's only a very, very slight tiny band here. So there's no real correlation between the antibody test and the PCR test. And this might be because the blood was taken too early and the antibody might not have developed at that time. And here we have another patient where we don't have any PCR result, and the patient has no COVID symptoms. So it's likely to be that this patient is COVID-free, but you still see a very tiny band here. So we have tiny bands which might result from cross-reactivity to other coronaviruses. Next slide, please. Summarizes you the data which we obtained and the conclusion we can make. So with a PCR analysis, we have many false negative data. With ELISA, we may have possible false positive data due to cross-reaction with other coronaviruses. If the data are positive, clearly positive, the question is if the antibodies which we have are really protecting us, so whether these are neutralizing antibodies. Next slide, please. And with this, we come to the vaccine development. And the goal is that we induce with the vaccine virus neutralizing antibodies in order to be successful and to have a long-term protection against the coronavirus. Next slide, please. So in order to do that, researchers try to develop neutralizing antibodies against the spike protein, because the spike protein will bind to the receptor, so to the angiotensin converting enzyme 2. And so this spike protein is the same as a receptor binding domain. And the receptor binding domain is somehow here within the DNA or the RNA of the virus, and we know the sequence. So we can now cut out here this piece of RNA, and we develop a recombinant receptor binding domain. And now we have 3 possibilities to use this recombinant protein to make vaccination. May I get the next slide on the right side? Just click once. Just click one more time. No, one more back. One more back. Oh, this doesn't work. So basically, what is left is here on the right-hand side. Next slide, please. So we have now 3 options what to do with this receptor binding domain. So one option would be we just put it together with an adjuvant. The second option would be to integrate it into an adenovirus. And the third option is that we use virus-like particles of a virus which is not pathogenic and combine it together with this receptor binding domain. And we basically follow this third strategy. And next slide, please. So we are quite advanced and we have a very ambitious timetable. And as you can see, we hope to have already October 1st, we have a vaccine ready for 5 million people where we would like to vaccinate the Swiss population. And then if we are successful, we can make more of this vaccine in order to distribute it also to other countries in the world. Next slide, please. So I would like to thank Professor Martin Fiedler, who runs the Center of Laboratory Medicine, who provided me the information about COVID-19 testing. And I would like to mention also Professor Martin Bachmann, who runs the development of the COVID-19 vaccine in our university hospital. Thank you very much for your attention and for inviting me one more time.
Thank you. Speaker, Professor Weizhe Zhang, Associate Vice President of NCKU. Professor Zhang, please.
Slide, please. So in my talk, I'm going to show you how we conquer COVID-19 at NCKU and what kind of technology that we have developed in Taiwan. Okay, so in particular, I want to mention industrial involvement is very important because this is an emerging disease and it causes a lot of death. So we wanted to have a product as soon as possible. So next, please. And this slide will show the paradigm of the management strategy for COVID-19. As you know, for the exposure, vaccination is very important. As you know, RNA vaccine, subunit vaccine, and in particular, we have a narrow particle vaccines in Taiwan. And as Professor An just mentioned, symptomatic patients are important. So in Taiwan, we have around 5% as symptomatic patients. But in other countries, you have 15 to 20% asymptomatic patients. We believe genomic data may play an important role. So we work with the Harvard Personal Genome Project to identify genome profile of the populations. And for acute proof concept diagnostics, RT-PCR, as just mentioned, RT-PCR antigen and antibody detection. And for treatment, as you know, it takes 10 years to develop new drugs. So now we are working on drug repositioning. Basically, we use antiviral drugs or antibacterial drugs to screen the new treatment. And of course, we also produce therapeutic antibodies. And when we come to mild or severe cases, personnel should see cares. So home care systems play very important roles. And hospitalization and for intensive care, ventilators play a very important role. Next, please. So next, I show how we work together. Okay, so here, this shows the news from NCKU. And as you can see here, you can find this news in our page, web page. So Innovation Center, NCKU set up COVID-19 Innovation Center. Of course, we also set up the testing station, as Professor Lee just mentioned. And we also have AI system. We have developed automatic pneumonia detection system for early detection. We also have a wearable device for thermal screening to detect infection. Next, please. We believe university innovation should seek the help from industry. So academic industry collaboration play a very important role. And international collaboration, of course, will speed up the whole process. So we're looking for collaboration for clinical validation and commercialization. Next, please. And once the genomic data of SARS-CoV-2 were identified, so we formed a team. It includes 6 PIs, 2 medical doctors, and 3 biotech companies. As you can see here, we express those viral proteins, including spike, nucleic peptide capsid protein, membrane protein, envelope protein, VOP, and ACE2 using yeast, insect, and mammal's expression system. And we also produce mouse and humanized antibodies. And in this talk, I'm going to show you how we develop rapid test. Of course, we also develop therapeutic antibodies and vaccines. And we also have done some basic study, including using cryo-EM to determine the protein complex, and we also have immunopathogenesis. And in this study, we work with the biotech company Legion. Next, please. And the next one is the example how we did it. So as I mentioned, we express those structural protein from SARS-CoV-2. And to produce antibody, most of the scientists using hybridoma technology, and we work with the Legion. But one company in Taiwan, AP Biosciences, they have a humanized antibody library. So we quickly, within 1 week, we can screen very good high-affinity antibody from AP Biosciences. But because most of the lateral flow analysis system has the sensitivity of a nanogram, so we work with the Resense. They have a special chips. Basically, they use charge change to detect the binding. So they will do the prototyping and commercialization. So of course, we will do the clinical validation at NCKU hospital. So we are looking for clinical validation with the international hospitals. Next, please. So this is the Resense. We partner with the Resense because of this technology. They have the detector already. So basically, we need a chip. And this, why we work with them? Because with this kind of technology, we can detect picogram level, okay? So we are able to detect COVID-19 even with very low viral load. And it's very ideal for COVID-19 screening. And it's very easy to use. You don't need sample preparation because it's a microfluidic system. So, you know, it is easy to be operated by general people. And it's fast. It only takes 15 minutes. And it has a minimal end-to-end turnaround time. It's only takes less than 15 minutes. And it's a scalable development. So, and it has a very low cost and assay cost. Next, please. And this is what we did. We want to detect 5 different bands. First of all, we have produced nucleic capsid protein antibodies. And we also have an antibody for spike protein, and for envelope protein, and for envelope protein, membrane protein. And we also produce ACE2. Why we want to detect 5 bands? This is very important for our decision making. For example, if Taiwan have very serious outbreak, then we don't have enough beds for the patients. So in this case, we may select 5 bands will be used to select the patients. If we have very mild infection, then we may only select 1 band. As long as 1 band is positive, then we send the patients to the hospitals. So that's why we want to detect 5 bands. Next, please. And these devices you don't need very high-end process, okay? So basically, we work with the TSMC. And this is not immunoassay. So we monitor the change of the binding using the charge differences. So basically, we monitor the charge change. It means the current change, then we can detect the binding. Okay, next please. So this is the advantage of Taiwan. In Taiwan, we are very good at manufacturing. So TSMC, as you know, is the #1 chip foundry in the world. So they will make the chip for us. And for the microfluid devices, we work with Retech. And for packaging, we work with the Zhongxin Electronics. And Wistron help us to develop the devices for the electronics. Next, please. And this is very important. We work with the PGP, the Harvard Personal Genome Project. And basically, we want to sequence the genomic data of patients as well as a SARS-CoV-2 virus. So we want to identify genetic variants may portend higher or lower risk. So we will include a phenotype information, weekly health assessment, whole genome sequencing, and the results of antibody test. First of all, we want to identify the genetic markers of death risk, as well as the biomarkers for asymptomatic transmission. So as long as we have the results, we can identify the high-risk patients. And we all want to identify asymptomatic carriers who may require regular screening. So because they carry the virus, so we want to avoid the unwilling spreading the virus. Next, please. So we also work with the MITEX, and NCKU work closely with the MITEX. It's a Canada-based non-for-profit organization. And they currently have 69 projects that are involving COVID-19. So they gave us the list. So we identify the PIs from NCKU who got the technology and want to work with the Canadian team. So our school and MITEX will team up to provide the funding to connect the expertise or researcher across the two countries and bring together a research collaboration. And this type of collaboration starts in 2019. So in my talk, I just want to emphasize international collaboration and industry collaborations are very important for speed up the process to help the patients in particular. This is very important for everybody. Thank you.
Thank you very much, Professor Zhang. Under a short notice, Professor Saban Taiken couldn't join this meeting. The panel comes to our next speaker, Professor Tevfik Damar, member of Board of Director, Turkey Institute of Health Administration, Turkey. Professor, you may start, please.
Thanks for introducing me, and thanks to the chairman and the president for inviting me to the meeting. I'm working at the TOBB University of Economics and Technology in the Department of Mechanical Engineering and Biomedical Engineering. And now my current position is I am the advisor-in-chief to the Minister of Health of Republic of Turkey. So I'm going to give a brief information about how the things goes on about the COVID-19 in the world, and the numbers with the Turkey. I will continue with how we did and how the things are going on in Turkey. I'm going to give a brief information about that. The thing is, this graph is, I'm very sorry for preparing the graphs in Turkish, but I'm going to try to explain in English, and I can share the slides. Who wants, just email me, and I will translate them to the English. Because of the limited time, sorry for that, all the notations are in Turkish. The thing is, this is the United States, and this graph shows the countries who they have the highest number of confirmed cases in a week. In the United States, it seems the 12th week, they have the highest number of confirmed cases. Or in Germany, the 10th week, Italy, this is the Italy, the 10th week they have. In Spain, the 9th week they have. But in Turkey, we have reached the highest number of the confirmed cases in the 5th week, the earliest in the world. And the second one is the Iran and the China. In China, it's the 7th week, and the Iran is the 6th week. So the thing is in here, which countries are reaching the highest number of confirmed cases early, they can find the potential with asymptomatic cases early than the others. So the China made with the quarantine, and the Iran did with the high numbers of the tests and the quarantine again. But the Turkey used the filiation method and can reach the cases early than the others. And this shows the highest number of the cases in a country, which week they have the highest numbers. For instance, for the United States, the 12th week, they have reached the 13% of all cases in the world in a week. And Spain get the 4% of the 4% of the all cases in the world within the 10th week. But the China get only the 2.7% of the all cases in the world just in the 7th week. And the Turkey, the same level with the 5th week, this graph shows. And this is the confirmed cases versus death rate. In the United States, they have, this is a 2 to 3 days ago numbers. And this is the number of the confirmed cases, and this is the number of the deaths. And 5.3% of the cases passed away. And in Spain, it's 10.5% for the cases. And in Italy, it is 13%. In Germany, it's less than the others, it's 3.5%. And the highest number in France is 17% of the total cases in the country passed away. In Turkey, it's 2.3% of the cases passed away. So this shows if you can reach the patients early than the others, they have more chance than the others for being alive. And this shows the number of the deaths in the world, the mean value, and the dashed one is, this one is the mean value of the world, and this one, the Turkey's situation on deaths.
He thinks I'm listening to it too.
And there is only China. And it's very quite similar with the China, our starting period, and it changed a bit. The world is increasing the numbers of the deaths because the other countries added up to the mean value. But the symptoms and the curves are similar with China and Turkey. The thing is, for the Italy, they have increased the mean value of the number of deaths in the world because it's uncontrollably increased the number of deaths in Italy. And this is the case in Spain, it's quite similar with the Italy. And in the United States, in a few days, they rocketed up the numbers of the deaths and decreased dramatically. And now they are familiar with the mean value of the world. They are parallel to the world's situation. And for the Germany, they have started later than the others, but now they are very parallel to the mean value in the world. And the United Kingdom is also seems uncontrollably higher than the mean value of the world on the numbers of the deaths in the world. But for the case in China, they have announced that they have controlled with the quarantine and the number of the cases stopped in here. But a few days ago, they have announced that under the quarantines, there are several numbers of the people passed away. So I guess the situation in China, the estimated situation was like this, as like the red line. But they have announced this one and they have explained, they have controlled everything. But the number of the death is increased in a day, which is very similar to the rest of the world, actually. And the situation in Turkey, we have tested over than 650,000 tests in total, and the blue bars are showing the number of tests per day. And now we are higher than the 40,000 tests per day. The PCR tests only we are doing in here in Turkey. No other test methods. We have the BT, but the cases, confirmed cases, are confirmed via the PCR tests, because we can make the test each and every individual who needs to get tested. And this is the number of the cases in Turkey daily based. The blue columns are the daily based numbers, and the orange one is the cumulative curve. And it shows that we have the similar numbers for the last 10 days, which shows we are on the plateau regime of the pandemic. And this is a good and important information about Turkey, how we deal with the outbreak. This shows the pneumonia rates in the cases. It started with the 60% of the cases, confirmed cases, became pneumonia in Turkey at the beginning, the 22nd of March. But today, it's only the 12% of the confirmed cases became pneumonia, because we are protecting them to become pneumonia, because we are starting the medication when even they don't have the symptoms, but the test results positive, then we are starting the drug hydroxychloroquine sulfate. So it is avoiding the virus to get inside the cell, and it's avoiding the stalking storm. And this is the key point for Turkey, reaching the potential patients early than the others and starting to avoid with the hydroxychloroquine sulfate, and then avoiding them to get intensive care unit, because when they get intensive care, they generally pass away, because the mechanical ventilation is not appropriate at the last stage, because we know that the golden standard is for the ARDS is the intubating the patient. But for the COVID patients, giving high flow oxygen is more powerful than the intubation. If you have a chance to give the high oxygen, high flow oxygen, it's more efficient than the intubation. When we have realized this, the number of the deaths and the number of the intubated cases, number of the intensive care patients are decreased dramatically. And this is how we have prepared to the pandemic. This graph shows the red one is okay, I'm completing. The red one is the number of the occupied beds in the standard beds, and the dark blue ones are the number of the intensive care units occupied, and the turquoise one is the number of the ventilators, mechanical ventilators. You see, for the outbreak, the 20th of the March, we have decreased the patients on services of the hospitals. And now, at the beginning of the pandemic, it was about the 67%, but now, today, the 6th week of the pandemic in Turkey, we have only the 32% of the beds are occupied by the patients, and for the intensive care units, only the 60%. So this is how strong the infrastructure of the health system in Turkey. And this is the health and age condition of the deaths. The most of the cases have one comorbid diseases, and over the age of 60 is 60.1%. And under the age of 60 and no comorbidities passed away only the 8% of the all death pool. And this is the age and the sex distribution of the deaths. The most of the men are more tendent to pass away, and the numbers are higher on the over than the age of 60. We have announced that curfew only for the over the 65 and under 20 years old people, the curfew, and it's dramatically changed the number of deaths in Turkey on that age groups. You see, this is before the curfew, and this on the right-hand side, it's after the curfew. and the number of this is the distribution of the deaths on the over the age of 65, and this is the over the age of the 65. It's dramatically decreased. And this shows the death rate for the cases under the intensive care unit. As I have explained before, intubating them increases the death rate. And when we have realized that the high flow oxygen is more efficient than the others, the number of the deaths on the intensive care unit and the ventilators are decreased dramatically day by day. And this is, how about not controlling the pandemic in Turkey? It's estimated that the 7,150 people will pass away. It was, if we could not control the pandemic, this is the prediction from the occurrence, but it seems that we have very well controlled. But how we have controlled with the affiliation studies, within 2 days, 47 hours, we are making the affiliation, and 98.1% of the, okay, I'm summing it up, 98% of the COVID positives and who gets in touch, who contacted with them, have screened and find as the potential patients, and it goes about the 99% of the affiliation studies. And this is the situation in Turkey for the simulations of the models. We have some mathematical models, and we have the movement-based models, how they move, and it shows, the simulations shows that in the best condition, we will end up the outbreak in the 28th of the May, in the mid condition, the 18th of June. The worst case scenario is the 1st of the January 2021, which is unexpected in here. We believe that we will be very well at the end of the May and the beginning of the June. Thanks for everyone, and thank you again for inviting me to the meeting, and I have very well informed about the presentation. Thanks again.
Thank you very much, Professor Debar. Panel discussion. Professor Zhang, please.
Yeah, so now we have panel discussions, so all the speakers are invited. So any questions? Yes, please. Yeah, please go forward. Let's.
Yes, my name is Sina Tahiri. I am from Iran, and I'm PhD student of oncology in Institute of Clinical Medicine. The first professor from United States, they designed the device based on the immunoassay. I would like to ask about this device can work in any environmental condition. Thank you very much.
A good question. We are now working on that. Eventually, excuse me, this is the thermal equilibrium conditions for the test. And then this is an overall result, coupled to the environmental changing of that. But actually, we're gonna do control by using the smart system. And we can do this one, right, without having any too much problem. All the analyzer has the same problem, but we can control as point of care, everybody using the same technology, and then some standard curve as well as temperature influence. Some standard, some table utilizing for the test.
Yes, please.
Hi again, I'm Dr. Emir Garcia from the Philippines. I'm a physician, and currently I'm a PhD student here in biomedical engineering in NCKU. Actually, my question is a follow-up with our international student as well for Professor An, because currently there are a lot of false negative when it comes to the rapid immunologic assay. That's one thing. How can we prevent this false negative with your current technology? Since it's just an antibody-antigen interaction. It's the same thing with the other LFIA, lateral flow immunoassay, that have a lot of false negative. And at the same time, since it's a POCT, would that mean that the chip is replaceable, or you just use one chip and then you can utilize it over and over again? Because for some areas, such as, for example, in the remote areas in the Philippines, not all do have their cell phones, and at the same time, not all can be able to buy this technology. And what do you think will be the cost of this chip, so that everyone, that it can be affordable to the remote areas? Thank you.
Well, that's a good question. Actually, right. So, as most of the immunoassay result, everybody, excuse me, now many company, excuse me, right, in the United States, now the FDA approval, RUA apply for the right, but still some company, why the false negative and then false positive is so low, and then we are unable to make a good decision, right? That I believe, right? Part of it because of that the chip and then the analyzing system, but major problem coming how we can define antigen pair. Okay, as only immunoassay. Some sensitivity, specificity, totally depending on the antibody-antigen pair. So Dr. Simon talked about that, his groups, and then he's now making how we can defining some spike protein and N protein, especially spike protein, how we can find some it is the specific, some protein, some motive, some binding motive, right? Who can think that is right protein to identify spike protein, and then based on then how we can make some antibody. That I believe that is all about many it's structural protein groups, many groups now is moving, learning to that direction. But who can find the right antigen antibody to identify, and then also differentiate over some noise, some SARS and the MERS very similar some antigen antibody. It is the pairs, right? How we can differentiate. Based on that, we are false negative, false positive, not because of system. Everybody has a trouble because of them. So we're gonna take a time to find the right antibody antigen pair. Anyone who can make is the correct antigen antibody can be the winner. But then maybe the connection to the previous questions and yours, I believe, right? This is the polymer chips is disposable, as you see. To avoid the cross-contamination, most of the early diagnostic kits are using some disposable. So yes, that's a good question. Some country, someone mostly has a smartphone, but maybe not. But still low and middle income country, we know that even the countryside, right? Many people has some smartphones. So not only individual, but one smartphone has someone we can testing based on this. So we are more provide affordable and the low cost than the individual approach. Possibly, of course, a lot of issue for the why, how we can make a clear way, how regulatory some policy, but it's depending on how we can handle for that. Thank you for the good question.
Yeah, but I'd like to comment a little bit about your question. I believe combination will be very important. For example, if you only use the RT-PCR, you only can get accuracy less than 60%. But if you combine rapid test with the IgM, then combine RT-PCR and IgM testing, then you can achieve the accuracy more than 95%. So that's the way to go. So basically, combination will give you better accuracy. So next questions, please.
Hi, I'm Po Chin Lee, a local medical student in Taiwan, and I just finished my rotation in hospital in Bach. So it's very good to see you again, Dr. Simon. So I have two questions. The first one is for Dr. Simons and Dr. Zhang, respectively as the director of each faculty. We believe that the university is also important in education, its function in education. In this period, we noticed that there are many innovative research or innovative approaches on outbreak response. As a medical student, I wonder how you envision or what is your current experiences in engaging students in this process as an important platform for research education in the process. And my second question is to Dr. An Chong again, that your inspiring work on the device gadget for testing kits. In many communities, due to the paucity of healthcare personnel and facilities, there are debates on if we should promote wide-ranged testing of coronavirus because of its potential false negative, false positive cases, and also its potential impact on psychosocial effects on patients. Because if they're infected, but there is no enough hospital to take care of them, and they will have to be compromised if they are not severe symptom patients. So from your perspective, how can researchers or possibly medical students do in this process, especially we are still not seeing that the situation of the outbreak getting better since January?
Thank you very much for the question. Actually, it's very nice seeing you again. We actually like to see many MD and PhD students who are here also in the room being active and interested also in contributing in terms of science and education. I have to say that the PhD students and the MD students who are already working in labs which are related, say, in infectious diseases or in immunology, they are, of course, involved in COVID-19 research. However, there are no newly recruited patients actually which are so rapidly recruited that they can work in research groups. And also, there's also not such an interest. Most of our MD students are very much interested to be involved in caring about patients, so to be really working as a doctor in the hospitals and help here to treat patients. But as I said, there are some PhD and MD students who are involved both in the development of assays, but also in the development of the vaccine. So thank you very much.
Thank you, Dr. Simon. And then this is Chong-Wan again. Most PhD MD students now is giving us some wonderful questions, right? Yeah, this is you see in the now United States, other country, how we can control of this pandemic at the beginning. Everybody says speed up, really diagnostic, okay? But then as you see, we have using RT-PCR and then immunoassay 96 based one. Of course, RT-PCR now still conventions take 6 hours sometimes, but it's not true. Sometimes someone visiting to the clinics in the laboratory to get a result. Sometimes, right, even the United States, it take 1 day or a couple of days, or now speed up for the way. So everybody wanted to say, why so slow? So we are this country now implementing the point of care system. Anyone can sample quickly on the chip and inserting to the equipment. The result is coming out within 10 to 15 minutes, right? That is how we can testing a point, okay? We can testing point, reach to the point that we take care of the patient. So I believe, right, your community, medical community, or diagnostic community, very, very conservative. So you didn't have any idea. You didn't have any problem so far using conventional approach, right? But nowadays, right, any pandemic, we give us some lesson how rapid, fast, okay, and then the this mass diagnostic of the tools, it is the very, very desirable and essential to prevent and neutralization of this pandemic now and the future. So I see the smartphone-based one still a lot of argument for the use positive. This is a false positive, which is false negative. But eventually, right, we're gonna work together, our science community and the medical community, right, understanding what's the issue, and then we can address some technological problem or the biological problem. We can handle it. So I don't have any single problem for the way. And then overall, also the level of chip based on microfluidic based on most of them qualitative, but you see so far most sociological things, right, based on qualitative of them is just the accuracy 94.5% and the specificity 94.5%. That is sometimes arguable. We can go to the 98 or 99% of the accuracy and the specificity. In that case, right, all problem what we are not confrontation to miss of the symptomatic or early diagnostic, we can handle it. So it's a good question. A lot of issue, but then we hope how we can, is now upcoming, is another pandemic, how we can handle this one. We believe, we're thinking about the get out of the nutshell and then move to the next level of this one, okay? It is the modern era. Possibly we can have a good hopes, we can have a good way to address all of them together, right? Thank you, wonderful question.
Yeah, please.
Hello, I'm Professor Yuan Li from the Aeronautic and Astronautic Department. I have a question to the Turkish professor. According to you, develop the prediction model of the fatality. So I'm wondering have you ever considered about the human fact? For example, as I learned from the news, the Italian and the Spanish had a very similar language system. So when the outbreak happening in the Italian, so the hospital cannot receive more patient. So the Italian patient flew to the Spain, and he caused the outbreak in Spain. So that means the language, especially the senior patient, cannot communicate with the hospital staff. So they will prefer to select some, have the same the similar language system or culture system country to take the care. So for you develop the prediction model, have you ever concerned about some human fact? That's my question, because I think Turkey is also the bridge between the Europe and Asia. So since the development model for the fertility for the death rate is very important to us. Yeah, thank you.
Thanks for the nice question. The thing is, in here in Turkey, the main difference in here is when we find someone COVID positive, even he or she has not the symptoms, we are starting the affiliation study. So we are asking to the patient who you get in touch in last 3 days, and we directly find out the family members and the co-workers of them from the main system. And in Turkey, different than the rest of the Europe, all the hospitals are directly managed on the IT system in Ministry of Health. And the only health provider in Turkey is on the payment base, the government. So the whole system directly, all the data is collected in a single station, which is inside the Ministry of Health. And all the healthcare services are managed and planned from the main institution. So this is the first difference between the Europe and the Turkey. And the second one is, most of the researchers in Turkey are working on the BCG vaccination the tuberculosis vaccination has a correlation between the COVID-19 and the others, but this is not proven yet. But I can easily say the first country in Europe who left the BCG is Italy. The second one is Spain. The third one is France. So there may be a correlation between the BCG vaccination and the COVID, who get the COVID-19 more severe cases. But this is not proven yet. In Netherlands, they are making a controlled study about this, and they have BCG vaccinated 1,000 healthcare professionals, and 1,000 of the healthcare professionals with the placebo vaccination. And they have proved that the BCG vaccination has an important correlation between the COVID. And it is also studied in India. They have found that 90% of the BCG vaccinators are more powerful through the COVID-19. This may be the main difference. But in Turkey, the first case is we are directly finding the potential patients. If someone is COVID positive without symptoms or with symptoms, we are making an affiliation study around that patient. So we are accepting them suspected patients. This is how we can handle the number of the patients. We can start the care earlier than the rest of the world. This is the main advantage of Turkey, the affiliation study. For instance, inside Europe, if you don't have the symptoms, you cannot get tested. But we are making tests in here. If you have a contact with a patient with COVID positive, you are directly testing yourself too. This is the main difference. And if you are also COVID positive, we are directly starting the hydroxychloroquine sulfate. So this is, maybe there are some cultural changes, and maybe the BCG vaccination has an effect on has a correlation about the COVID-19. But the main thing is we have a strong infrastructure for the health system and managed from the main directorate under the Ministry of Health, and starting the treatment earlier than the others, and the affiliation studies are very important for us. These are the main advantages of Turkey on the number of the deaths. Thanks for the question again.
Any questions? Actually, I have a question, because this session is for global research partnering. How can we work together? For example, Professor Ann, he got a device in the United States, and Professor Simon, you got a device in Switzerland, and I got a device in Taiwan. So we had to do some parallel comparison. So we had to fight with each other, okay? No, we want to help patients. So how can we work together? Because all the countries got emergency use authorization. I don't know about your countries. How can we work together to speed up the development? So can you, all the speakers can comment about this issue?
Maybe I start.
Yes, Professor Demar, you may start, please.
I am answering, right?
Yes.
Okay. In Turkey, we have the unmet medical needs. It is the high flow nasal channels. If someone working on those, we want to get in touch, because we believe that the high flow oxygen is more efficient than the intubation. We have mechanical ventilators and with the enough numbers, but we need high flow nasal channels. This is the main demand in Turkey today, and we can share the treatment protocols with all of you. how we start the patients with which protocols we are using at the beginning, and we can share the details of our affiliation method, how we do is. So if anyone needs them, please email me and I can answer easily the treatment protocols and the affiliation method in detail. On the genomic data, it's not my field of expertise, but I can get in touch with the professionals in here, and I can make the connection with the professionals from on your side and on our side too. Thanks.
Thank you, Professor Demar.
Can I?
Yes,
Okay,
Professor Simon, please.
Yeah,
I'm
maybe I. Thank you very much again that I can speak here. So I think that's a very interesting question, which I also asked myself. If we watch what's going on in this pandemia, is that each country is doing their own regulations and they try to control the situation in their own country. And I feel that there's not enough collaboration. There's no working together, really. I mean, we close the borders in Europe, and even within bigger countries like Germany, or even smaller countries like Switzerland, you know, we have very close, very smaller provinces. Even there are differences in handling the crisis. So I think instead of everybody doing his own thing, I think one should work more together. And I think one of the things which I appreciate is this conference, what we are doing here, so that we try to exchange ideas, to distribute also knowledge, so how things are handled somewhere else, and to learn from each other. So I think this is one important conclusion. The other thing is, for example, what we do in Europe, that we have European grants for COVID research. So this was a very rapidly established program, and here researchers in the different countries, they can come together and work in terms of research and to find solutions how to fight against COVID-19. So, and of course, if there are individual projects, that's clear that the researchers, you cannot everything organize top down, so that the individual researchers, they have to find their partners also in the different countries, and to build up international teams bottom up. So thank you very much.
Okay, Chong, okay, thank you, Dr. Simon and Dr. Dimmer. Actually, Dr. Simon's talk is very good and inspired me. I have working on immunoassay special platform last 25 years. So not only for the mobile phone based on immunoassay, the POCD, I have many platforms, but last 2 or 3 months, I spend a lot of time to find the special S protein assay kit, because my laboratory doesn't have any ability to make antibody antigen pair. But you see there's some science Nature paper, everybody different level of it, right? And then what is there, CR3022 to CR3014 or blah, 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 coming different antibody antigen. This is they are reporting. But for example, Dr. Simon's, the university and hospital has so many good antigen antibody pair. You can have it. We can have it, and then we can test it quickly. Actually, the implementation of the U-chips rapid kits, it's not take 1 or 2 months for the while. But I spend, because of the starting this on the China and the European community here, moving to the United States, a little bit behind to find such a material. But I had some big trouble to find the material, okay, especially acid protein. But any other country have it, especially some Taiwan also. Your country has a nice jobs for developing some rapid kit. We're gonna internationally working together. We can speed up for that as well. And also still United States, NIH, especially COVID-19 special project, international collaboration project, a lot, okay, especially very focusing on that COVID-19. So you can NIH and then everybody, you can write a pattern, you can find it. This is the extensively focusing on moving toward to address, overcome this COVID-19 United States is now working hard, and everybody now learning for solve this problem. So anyone you can have so many specific good way to address this one. You can contact to any university of research in the United States, including myself, and possibly you can opportunity. And we also have so many opportunity to overcome this pandemic altogether in the worldwide. Thank you.
Because we have to, time is up. We have to move to the other event.
Yes.
So,
next part of the session. Thank you. Thank our panel speakers. Thank you very much. Special report. Speaker, Dr. Yilin Xu, Doctor of Medicine, Director of International Medical Center, NCKU Hospital, please.
Okay, ladies and gentlemen, Chairman, and I think after the whole day, very academic speech, everyone is tired. Okay, so please be relaxed. I will tell you a story about our international collaboration for COVID-19. I'm Dr. Xu. Actually, I'm a surgeon, but I have the public health PhD. And I respond for the International Medical Center in my hospital, but it's under the university. The next. For my unit, we have a long-term international cooperation program, including the India, Myanmar, Nepal, Vietnam, India, Kenya. All the programs are long-term maintained, and every year we have a new process. The next. Since 2016, Taiwan government have the new southbound policy. So we want to have a deeper relationship with the southbound countries. Next. So the Ministry of Health and Welfare, our big boss, let's have the strategy, one country, one center. Luckily, we respond for the Indian program. Do you know how many population in India? 1,000 million population in India. But in my office, in Taiwan, we only have 23 million. How we can run this huge program? The next. Besides our academic exchange program and the skill training, we have a new mission. We need to promote the Taiwan medical industries. So we bring the Taiwan medical industry company to the India for the conference, for the expo, to visit the hospital, to visit the user and the buyer. And otherwise, we also host the B2B seminar by our hospital. And we also bring some Indian medical staff to Taiwan to visit these companies. The next. Fortunately, we have very long start with the AIMS, our Indian Institute of Medical Science. It's the highest level of the medical service and the school. And thanks to our Vice President, Professor Shu's introduction. So we have a link with the AIMS and Apro Hospital. Apro Hospital, there are 80,000 beds in this hospital. So we have the connection with the biggest and the highest level with public and private hospital in India. But we also have some link with some NGO and some electronic commerce and some private hospital group. The next. Okay, but after 2 years of effort, we set up the Taiwan Interdisciplinary Medical Team. Why we have this team? Because in India, we have very famous Taiwan wheelchair company. It's named Karma. It's more than 40% marketing and have more than 1,400 stores in India. So based on Karma, we have a concept, we have an idea. We set up the Taiwan M team. It's not only the slogan, we cross-linkage. We include more than 40 Taiwan medical industry companies inside in this team, and we support by our government offices. The next. Before 2020, how to implement international cooperation, especially for government program. Some officers sit in the office Let's think about some idea, okay? So we found some hospital, university, legal foundation, NGO, and we need to find international partners. And we host the conference exchange program. Everything funded by the Taiwan government. This is, I always call what we want, but not what they need. How about the effect? Yes, we have a KPI, but for me, it's only the number, not the real effect with our local partners. We run this system, this model, more longer than 30 years or 40 years. Okay, the next. But when COVID-19 pandemic, what happened? All flight between Taiwan and India stopped. We have 3 major missions. The International Trauma Conference in India and Taiwan, and we also invite Korea, Japan, USA professors. The PET system set up in AIMS, pre-hospital EEG in Delhi area, we cannot implement. And we cannot go to the Indian for the medical fair and Taiwan Expo to introduce the Taiwan medical industries. And we cannot meet our new partners, the Center of Innovation, Bio and Design, the Indian Council of Medical Research. We cannot meet them. Everything broke. So our running well model, because of the COVID-19 pandemic, everything stopped. And we call our good friend, the director of AIMS, Dr. Ron Deep, but he is very busy to fight COVID-19. So he did not answer. What we can do the next step? The next. Okay, fortunately, our local friends, partners, they have the local healthcare pharmacy companies. They have some motivation, they have some need. So they find the local public relations company, the PR company. And this company with very long-term relationship with Taiwan, the TITRA, we call the Taiwan External Trade and Development Council in the Indian office. So through TITRA, they find us because they know we are responsible for the Indian program. Okay, we think about what we can do. So after 1 week, we have the webinars to local audience. And this is very practical. After the webinars, all the media, government officers, embassy, every kind of organization to visit us because they see the number of the audience. I don't know how many audience at this time. Maybe everyone disappeared. Okay. So this is, we call the model is what they need, not what we want. Do you know the political or practical, which side is most important? For me, both sides. Because we have the political side, we have more and more resource and support. The next. Okay, this is very good digital marketing, please. The film. It's made by the local PR. Okay. No, I insert the film. It's a very good advertise and a very good promotion film to promote Taiwan, what we did for the COVID-19. The last. Ken? Sorry, I think the logistics always very important. Yeah, for us, my office only 3 logistics, and one my director, and the other 2 vice directors still on the paper need my boss permission. Okay. It's made by the Indian PR companies within 3 days. Okay, you can jump to the next slide. So it attracts many audience. Okay, on April 2nd, we have the first, the webinars. Total audience, almost 9,000 people. It's an amazing number. And this through the Indian PR company, and we spent 2 weeks, actually 1 week, because my college always complain me. We set up the equipment, connection test, and the speaker and the lecturer prepare. But most difficult is the permission of my hospital accounting office, because I'm from the government side, so we need to follow every kind of the rule they need. Okay, Professor Chen is an infection specialist, he's director of the COVID-19 screening station. He is very experienced. So after the 9,000 people, all the Taiwan median to visitors, so we have the very good exposure. And then the New Zealand, the ones at the Tier region, had an online interview with Professor Chen, the next. Okay, very successful, the first event. Then the clients request the second time. So we host the second time the webinars. It's Dr. Lee, he's also an infection specialist. We also invite the Dr. Shika. She is a PhD student in my university, and she's also a faculty of Indian Institute of Public Health. Of course, the Director, Science and Technology Division from government side, Professor Wang, joined us. After these webinars, we connect with the Dr. Himash. He's a professor of the Indian Institute of Public Health. We talk about co-research for the surveillance system in India in the field. The next. Okay, so what we got order after the pandemic, we got the last order from the Indian, USA, even Armenia, very many orders. So I passed the order to my team. If they cannot offer, we pass the order to the government. The next. So Taiwan really can help. The next. Okay, we can supply the medical device. But besides this, we can share our very good strategies. The next. But my Indian friends sent me a report. He told me, you always say Taiwanese is number one. No, I think the Indian is the number one. It's a report from the Times of India. It's titled, India, Canada, Australia among top to control COVID outbreak. For the number of days to double, India is number one. For the number to test conduct reach 5,000 and 10,000 patients, India is the second best. For the total case per 1 million population and the deaths per 1 million population, India is best one. So he told me, no, Taiwan is not best one. India is, okay, I totally agree. And he showed me his experience. He told me, you a Taiwan guy, the expert, always tell us, no evidence, don't use these drugs. But in India, do you know how many patients we need to deal with? So they use the hydroxychloroquine for the prophylactic for the medical staff in Delhi, the biggest hospital. But in Taiwan, we always suggest don't use this because too many side effects, no evidence. But they say in India, they have the hydroxychloroquine, the protocol, how to use it, the guideline. Okay, so the next. What will we do? We will host a third webinar, but we change. We use the panel discussion. We want to have more interaction with our audience. And we cooperate with the Bangladesh government through TITRA. And we will offer the online medical consult for Taiwanese in India because now in India, we still have the 400 Taiwanese there. So we have the line group and offer them the medical consultant and the new information. Of course, the embassy also included is. We still keep connection with our Indian partners because we worry about them, and also we want to share from them. The next. Okay, I think the Taiwan will be the good partner to improve all the world, the good health and the well-being. The next. But we need to think about that. After COVID-19, how about the motivation? Before, I'm the humanitarian, but now I'm like a businessman. I think no business model, we cannot run everything. So we should create the win-win situation for everyone. And that everyone has a strong motivation to participate in this project. Sorry, that's. And the second, how to implement our project. Because after the COVID-19, we know we don't need so many transportation, we don't need so many accommodation. We can save money to host the webinar and online, can do everything. But the most important, we need to put ourselves in their shoes. We need to think about what the real situation in our partners, not always by Taiwanese experience. And we need to interdisciplinary team. It's not only the slogan, it should be a close link with our government side, our business side, the academic side. This will be real practical. Finally, as my boss, the president of the university, Professor Su said, Taiwan cannot help. We are together with everyone. We help each other. Thank you. It's my special report.
Thank you, Dr. Xu. Let's welcome our next speaker for the special report. Speaker Lisa Maigas, Vice President, International Partnerships of MITEX, Canada.
Oh, can you hear me?
Yes, we hear you. Hi, Lisa.
Okay, very good. Thank you. Thank you so much for having me. It's wonderful to be here, and thank you very much for assembling this very important forum and to our NCKU hosts. MITEX has been a partner of NCKU and the Gloria program for over 1 year now, and we're very delighted with the partnership, and we're very much looking forward to deepening our relationship around this COVID-19 issue. MITEX is a Canadian non-for-profit, and we have been in partnership with the Canadian government for over 20 years. We power research and development by connecting industry with the best post-secondary institutions to solve business and societal challenges in Canada and internationally. So we receive funding from the Canadian federal and provincial governments, and we work with all Canadian universities to boost R&D and innovation in Canada and internationally, and we nurture the next generation of students by training graduate students for their academic and industry research careers. With regards to COVID-19, our goal is to ensure that the stakeholders involved in COVID-19 research can get the resources they need to find solutions faster. The Canadian government is supporting research priorities that are laid out by the WHO and GLOPID, our roadmap, as part of the global efforts against the pandemic. So we're working on medical countermeasures, including vaccines, diagnostics, and equipment, and social and policy countermeasures such as public health response, governments, and logistics. We support and foster research in these priority areas and adapt our program offerings to better respond to the ecosystem's needs. We're working on COVID-19 related research to address the pandemic, and we have therefore set up initiatives to support researchers and companies directly involved in the fight against COVID-19. To do so, we're fast-tracking all of our proposals that are related to COVID-19, and we're offering more flexibility to conduct research virtually, including projects between Canada and Taiwan and Canada and our other partners. We have partnerships with 22 governments, and we're trying to be a conduit between companies and researchers that are working on COVID-19 projects between Canada and Taiwan and other countries through our partnership with NCKU, for example. We're also incorporating colleges into some of the projects to help commercialize some of the products and services and technologies faster than they would otherwise be commercialized. So we're playing a role in matchmaking players from our worldwide networks, both domestic and international. So working with government, universities, and industry We have a team of 80 business development people that are across Canada and building projects with companies and universities where graduate students will play a major role in facilitating these projects. We're also coordinating with other Canadian organizations, such as the Network of Canadian COVID-19 Researchers. It's called CAN COVID, which reunites clinical collaborators, healthcare stakeholders, to facilitate communication, coordination, and collaboration between the scientific, healthcare, and policy communities during the crisis. MITAX is the moderator for the industrial research thread of CAN COVID. MITAX has been in coordination with sister organizations, and we're working very closely with the National Research, NRC, CIHR, SHRC, and NCERC to align Canadian priorities, leverage Canadian efforts, and scale up the capabilities to meet the immediate needs and support economic resilience and recovery in Canada and with our international partners. In terms of supporting collaborative research projects between Canada and international projects, we have a program called Accelerate International, and we're working very closely with NCKU. As was mentioned, we're doing calls for projects with companies and non-for-profits related to this area. We've shared the list of projects, and we're also excited to work on some of the projects mentioned today together. The way that the program works is that it's a 4 to 6 month research project, which can be done virtually, involving a Taiwanese company and a Canadian research institute or research group, or vice versa. It could be a Canadian company with students from NCKU involved doing the project virtually. We share the cost of the grant for the students doing research, and we could do multiple students involved in the same project, up to several $1 million for an individual project. And the funding that NCKU and MITAX puts in through the government is leveraged and matched by the company that's involved. So we would be very interested in partnering with Taiwan and with other countries involved in this call on medical imaging, AI analysis. Canada is very strong in AI and quantum, and we see a really important role for AI and quantum in some of the diagnostics and analysis, frontline medical robotics in hospitals, medical countermeasures, including tests, diagnostics, vaccines, antibodies, and also looking at policy and social measures, including the impact of isolation on the elderly, stress and anxiety, and public health policy, as well as preparedness for future pandemics. As I mentioned, we have a partnership with MITAX, between MITAX and Gloria NCKU for student-to-student academic partnerships as well. So once students are able to travel, we would be very enthusiastic about doing larger scale projects between NCKU and other universities in Taiwan and Canadian universities. We represent all Canadian universities to work more fully on AI, quantum, and other areas which could prepare us better for future pandemics. And so we look forward to building on the strengths that we have between this partnership and expanding to other universities in Taiwan to tackle some of these very important issues. Thank you very much.
Thank you very much, Ms. Mayas. We finished the special report of Section 3. And about the next part of the section, Professor Peter Lennon of WUN, Worldwide University Network, he's experiencing some technical errors and he couldn't join the meeting at this moment. We got connected with Professor Peter Lennon this morning successfully, but this problem is unforeseeable and unexpected, and we are sorry about that. So Section 3 will come to the last part, Way Forward, concluding remarks by Professor Huizhen Jenny Su, President of National Cheung Kong University and Chairperson of SATU President's Forum. Professor Su.
Mike cannot join yet.
No.
Is that Mike from the
We are sorry about that.
Fine. This has been rather long. I wonder how many of our speakers from the last session still remain online. I see friends from Switzerland. I see friends maybe from Turkey and other places. But in any case, thank you so much for staying online with us. This has been quite a challenge for NCKU. I think we made a history as well. This is a nonstop 12-hour-long virtual forum starting 9 o'clock here, China and Taiwan time. And this is approaching 9 p.m. here. And I'm most thankful, actually, for my colleagues for putting through this together, for the support from Cisco. But above all, is to each and every one of our friends from different parts of the world. We began this morning talk about the university challenges and see how we can all be resilient together in confronting either the emerging crisis or the other sort of difficulties we have in our own sector. And then we move in the afternoon, starting with the science and technology related to either the medicine or the healthcare itself, but for the society in general. And the last session, we specifically aim for networking. It's a platform that we will build together, and it's the power of networking that will be the only way that we remain hopeful as we encounter the ever more challenge and issues coming around different parts of the world. Regardless, it's the differences in culture, it's the disparity in wealth, or even the appreciation or our undertaking in adopting technology into our life, or even translating our discovery into the application of the possible issues. So what I intend to really make it happen is that after today, that we would have a continuously operating website in the name of confronting COVID-19. We'll continue to put on information that we can collect from each and every one of our partners. And as my colleague had mentioned by Professor Zhuang and Deputy Minister Xie this afternoon, Taiwan would like to serve as the ultimate platform for everyone around the globe, so that with knowledge, with our empathy, and with that very genuine intent to make a better human place to live and to thrive together, we hope we will be that very, very cornerstone. We will be that key engine to drive everything and putting it forward. So looking beyond, we would have you in our picture, and hopefully you would have us in our picture together as well. And together we will draw the map, and we will have the entire roadmap become possible and feasible for everyone to be realized and fulfilled. So with that, thank you. It's good morning or good afternoon, or it's going to be good night for us here in Taiwan. So we will see you at one point of the time, either here or there or somewhere through virtual world. Again, bye-bye.
Bye-bye.
谢谢.
Thank you very much. Thank you, Professor Su, and thank Professor Zhang and all our panel speakers and the participations from our audience all around the world. We hope to be able to meet you again very soon. Everyone have a very nice evening. Thank you very much. End of forum.